Good morning, everyone. We're going to get started here in just a moment. I believe we're waiting for another senator or two so that we can get going. So if you're listening in your office, this is the time to come out of your office. So give us just one more moment. Madam Secretary, if you please go ahead and call the roll.
Senator Parks. Senator Kiefer. Senator Smith.
Here.
Mr. Bobzien. Mr. Hambrick.
Here.
Mr. Hickey.
Here.
Mr. Horn.
Here.
Mrs. Kirkpatrick. Mr. Kerner. Mr. Sprinkle. Chair Carlton.
Here. Please mark, I think do we have everyone? We're good. We're fine. Wow, didn't have to do an adjustment this morning. First of all, the standard discussion of cell phones, laptops. We're all very familiar with those policies. Also, you'll see the members working off of their laptops. Everything is loaded into our Nella system, so you'll see them working off of that a lot. Apparently, there was a problem with a request on video conferencing. It was made very late, and if we don't request video conferencing very early, we don't get it. It's in high demand. Today, we're actually using the governor's conference room also for video conferencing to make sure that it was all able to be covered. So if you ever do want video conferencing, please let us know as soon as the committee, as soon as your issue gets scheduled, so that we can reserve it. That's one of the things that we've become very reliant on, and everyone wants to use it, but there's only so much capacity for it. So with that, this meeting had not been was not scheduled to be video conferenced, and we just can't change that at the last minute. So with that, we will go ahead and begin this morning with our presentations. Let's see, we have the Department of Health and Human Services, Aging and Disability Services. I believe Ms. Gruner.
Good morning.
Good morning.
I'm Jane Gruner, and I'm the Administrator for Aging and Disability Services Division. And with me at the table, to my right, is Dr. Tracy Green, State Health Officer. To my left, Janet Murphy, my Deputy Director. And next to Janet is Ellen Richardson Adams, who has recently taken on the Clinical Program Coordinator for early intervention. First, we're going to start with an overview of where early intervention has been and a little picture of where we would hope to take early intervention. And Dr. Green will start with that, and then we'll go into our DEC units.
For the record, Dr. Tracy Green. I serve as the State Health Officer and Medical Director for Mental Health and Developmental Services. Just as a brief overview on our first slide, Nevada Early Intervention Services serves children birth to 3, but we also have an integrated program, so we do attend to children as they age through the ages of 0 to 18 through maternal and child health, but early intervention services is primarily for children 0 to 3. We are essentially authorized to provide these services through the IDEA Act, which is Individuals with Disabilities Act. It's essentially an act that authorizes fair treatment of all children. On the next page, really looks at the funding of early intervention services. And what I wanted to just draw your attention to was that the predominant funding for early intervention is general fund. And then we do have a small piece from IDEA Part C, which is the act, the federal funding that I described previously, as well as dollars from Medicaid, and the other are primarily other insurance funding streams. But despite this funding profile, we are mandated to adhere to some very strict rules that are part of Part C. On the next page of our presentation, really, in the history of early intervention, I know there are a lot of words on this page. What I just want to summarize is that early in the 1950s, early intervention was intended and was initiated as a purely medical program. It was the Special Children's Clinic. And when Part C came into the picture in the 80s, it became an educational program. By 2003, Mike Wilden attempted to bring the educational piece and the medical piece together and created early interventional services as we see it now, with the idea that it would be a medical and educational program. From 2003 through the present, what we have seen is a lot of difficulty with the integration of this medical developmental / educational program. And I think what I'd like to draw your attention to is that in 2012, we've had a number of issues with physicians, physician complaints about services. We've had issues of community service questions. We've had questions about audits. And what it has done is drawn our attention to 3 areas of focus that are critically important as we move early intervention forward. One is the standardization of the intake process. The second is the development of a quality assessment program. And the third is the development of the medical component. On the next slide really looks at what I'm speaking of as we move forward for early intervention in the future and how we're going to deliver services. What I want to say is that when parents are referred to early intervention services, what they know is that their child has an issue. They don't know if their child has a developmental problem. They don't know if their child has a medical problem. They just know that they've been referred because their child has a problem. And most of the referrals to early intervention come from 2 places. They come from hospitals and they come from physicians. So what we need to be is the single point of entry, and we need to be the intake center of excellence. We need to have a single point of entry for our families where they can get screened and assessed. Once we have that standardized screening and assessment process, we then need to determine, as is shown in this picture, is this a medical child? Is this a pure, what we would call Part C, or educational child or developmental child? Or is this the child that might require some medical services and then be able to get some of the educational or developmental services? But in addition to this, we need to enhance our quality component. Currently, we rely on the quality from Part C, which is essentially, is there timely services and is there timely delivery of services? We need to start looking at outcomes. We need to start having oversight not only of ourselves, but also of our community partners, and we need standards and protocols. On the next page, I really speak to the waiting list. Currently, there are 481 children waiting for 691 services. What I want you to understand is that there are no children waiting for all services, that these are children waiting for some services. On the following page, it really just delineates for you a little bit more specifically about what services children are waiting for. But I do want to spend a couple of minutes talking about the waiting list. Really, the waiting list is not just a fiscal issue. I do believe that given the work programs that we have moving forward, hopefully in April, and the money budgeted in the budget we're going to present to you, we have the fiscal component. But what we have a problem with is more than just finances. We have a problem with resource. We have a problem with recruitment of appropriate developmental specialists. We have a problem with medical professionals in our community. One of the things we have already done is hired full-time medical staff both in the north and the south to begin to develop a more stable medical professional staff. But you're going to hear today that we also need to develop some medical specialties. We also have a shortage of providers. In rural Nevada, in some areas, we have no providers. We have no developmental specialists. So the state is the only provider of all services for children in some areas of rural Nevada. We also have what I would call a hybrid service here at the state. We have contractors at the state that are part of our community providers. So we're used to hearing the word there are community providers and there are state providers, when in actuality we're all sharing one provider pool. There just aren't enough providers to deliver all of the services that are needed to our children. So what we have to start doing is looking at new ways to deliver these services. Some of the things that we've begun to look at is, should we be doing RFPs for services where we require some of our community partners to deliver services in more broad range? So perhaps they have to expand their services to radiuses to include some of our rural services. You're going to see in our budget requests for iPads because telemedicine has become really important for some of the delivery of services. You know, in past, the issue of the home environment or the natural environment has been a question. Do we need to look at, do we provide services in groups? So again, we're going to need to look at the service delivery model and how we provide the services as we look at bringing the children off the wait list. The next slide again speaks to, are we going to be able to commit to 55% of the children going to community providers by 2014? We believe the answer to that is yes. We are going to move children to the community providers, 55% of them by 2014. Again, we believe that can happen as we enhance our quality oversight, as we train community providers, and as we get more of those specially trained providers, and as we support the university's enhancement of their medical professionals, and hopefully as ACA brings us more primary care providers. In addition, in 2015, we do believe we can get to that 75% number as we move in the direction of the whole provider network and delivery of services model changing. The next slide really states what we've had so many rumors about, which is we are not eliminating any positions. In fiscal year 12 and 13, there were 170 positions. The budget asks for 171 positions in fiscal year 14 and 15. The rest of this slide really points to all of the positions that have been previously noted as, quote, frozen. We have no frozen positions. They have all been open, and they are in multiple levels of being hired. Some are open and have lists. Others have already been hired. But all of them are listed for you so you can see where we are at in filling all of those positions. The last slide in this opening presentation just really speaks to that integrated point. We believe that early intervention services can be that one-stop shop for families where they can enter the system as a child, where they can be smoothly integrated into the schools, ultimately, if needed, get to developmental services, and finally be a part of aging and services and get the services they need there. This is the organizational chart that shows the move for developmental services, for early intervention into DS, and ultimately into aging and disability services. And I'd be happy to answer any questions, or we can move to the decision units.
We'll go ahead and open it up for a few questions now, and then we'll get into the decision unit. So with that, Mr. Bobsian.
Thank you, Madam Chair. Good to see you again. Feel like we're right back into the discussion, and I think it would be helpful to have an update from the last time this came up. We heard that there was going to be some vigorous conversations with the physicians community, pediatricians, others concerned about the changes and what that would mean for services. Can you provide us with that update? I know that you mentioned you were talking about hiring medical professionals to have some interface with the docs, and that's encouraging. But if you could talk a little bit about that, and then also specifically the concerns that they had with some of the providers.
For the record, Dr. Tracy Green, through you, Madam Chair, to Assemblyman Bobsian. First, I would like to say that, yes, we have had a series of meetings with at least 5 of the concerned pediatricians. I'll start with the direction that we are heading in with quality assessment, with sustaining our neonatal intensive care unit, with the focus on the medical child, and with how we approach the intake have all been driven by concerns from the pediatric community. I would also like to say that the quality team will be headed by and participated with Dr. Coletti, who is also here today for public comment. As far as their concerns, there were a number of concerns surrounding some of our community partner issues, but I think the primary concern that they had were surrounding children being inappropriately sent to community providers before receiving adequate medical assessment at early intervention and being adequately treated and or screened for those medical conditions at EI. And so this medical screening and assessment and having a full-time medical specialist at both EI North and South has created a scenario where that no longer will happen. So I think that has relieved both of those situations for the pediatricians.
Thank you, Madam Chair. If I might, I know that one of the other concerns, though, was that kind of the wraparound piece of this is being able to assure the quality on the back end and the communication back to the doctors after referral and services have been delivered as well.
For the record, Dr. Green, that is a part of what is in development as far as the quality follow-up. Again, Dr. Coletti is part of the team. We have a meeting scheduled for next week for what will be the 10 quality measures. Right now, we do have a system for referral and communication. We're actually working with the pediatric community for how they refer into us, because oftentimes it's a phone call by the family who's been told by their doctor that they need to come to us. So we don't even get a call from the doctor. It's from the family who's been told by the doctor. So we also need to do some training with the community pediatricians and family physicians to get a better understanding of what the process is on the front end so that we know who those physicians are on the back end.
Madam Chair, I don't know, do you want to go into the decision units now for caseload and everything
I was
else?
going to
or
open
do
it
you
up
wanna-
for other committee members if they
Okay.
had any questions on the general. Yes, Mr. Sprinkle, and then we'll get into the decision units. Yes.
Thank you, Madam Chair. Good morning. Just to kind of follow up on that, once these children are actually in the whole process, as I understand it, you're moving more towards an oversight as more and more community providers are involved in the actual services provided. Who handles the complaints when, say, a family member feels that their child is not getting the services that they should be getting? Is it because typically I would assume they would go straight to their physician. With your oversight, who exactly is going to be handling that?
Jane Gruner for the record. Currently, Part C, under Aging and Disability Services Division, handles the complaints, but it is in development. The quality piece will assume not only, we'll be dealing with the complaints also as an overarching part of our quality team, so that it's followed through with, if there's a complaint, if it's substantiated, who's going to be helping that provider to correct whatever the complaint was about and close the loop.
Thank you. And then just to kind of dovetail on to Assemblyman Bobzien's question, so once that occurs, now you feel more confident that that communication is then going to get back to both the parents, but then also the physicians that are involved in this as well.
Correct.
Because the way I
will
understand
be-
it, even though I'm new, I understand that this was a concern from the past.
It will be part of what happens to close a case, to close a complaint now.
Other committee members? Mr. Bobsey, did you have something else?
Thank you, Madam Chair, for the second, but that starts to, open up more questions for me when I hear that response. Can all complaints be corrected? In other words, and I appreciate that, you would work with the provider and try to rectify the situation. You need to substantiate the complaint. You need to see if there are ways that you can work with the provider to, close the loop and make things correct, make things better. But at what point do you say, this is clearly a quality problem that cannot be corrected, and we need to act to make sure that this doesn't happen to other kids?
Jane Gruner for the record. Great question. That is, again, part of the quality improvement that will be happening is what are the standards, and at what point, by not being standard, will you be allowed to do service? So that is going to be part of the process that happens during this work group. Right now, Part C has standards for that, and as long as the provider meets their standards, they're allowed to do service. But until now, we haven't actually looked at the front end of that piece. Part C does the back end. They look at complaints after they've happened. We want to do a lot more front end work for our quality, so we're doing more training. Our quality people are in the locations, actually seeing services being delivered. So we will identify what are the red flags that indicate a provider could be in trouble.
Okay, so, and if I might, Madam Chair, so if you have existing audits from Part C showing that there are problems, that's a red flag, right?
It's a red flag.
Okay. And so,
Something on that, Mr. Bobsey.
okay, thank you.
Thank you. Any other questions from the committee before we get into the audit? All right. Speaker?
Thank you, Madam Chair. So I just want to ask kind of a different question. So the biggest complaint I hear from my constituents is that when the provider or the community partner comes out, that they got to see 3 different people in the same day from the same group for a particular service, and then we bill 3 different ways. So is there not a better way to get a full assessment for the kids? That it just seems that we could be more efficient with our dollars and get the other kids that are on the waiting list service faster than having 3 different groups come out on the same day for 3 different things that are intertwined. It's like sending a kid to a pediatrician, but walking them over to family practice and then walking them over to a specialist is what my constituents tell me in the service. And most of them are foster care providers or different things, and it's already traumatizing for the child, and then they go through this. So how is that ever addressed?
Good morning, Ellen Richardson Adams for the record, through Madam Chair.
You can go directly to the member.
Thank you,
There's going to
ma'am.
be a lot of questions today.
Thank you, I appreciate that. And so looking at how evaluations take place for a child to become eligible, there must be more than one discipline, one professional to help make that decision. It needs to be at least 2 different professionals from 2 different disciplines. So that may help answer some of the question of why is there more than one person. In terms of the logistics of are they seeing, a 10 o'clock, 11 o'clock, and 12 o'clock? That's something I can go ahead and review and look back at. That's generally not the standard practice. We like for families to have to tell their story once. It's a long process, and it's not helpful for families. And so if you would allow me to go back and review that process and see how particular programs are handling that, I'd be happy to do that. But we do recognize that best practices, having the 2 different plus professionals at one appointment to help gather that story and determine if the child's eligible for services.
Okay, thank you. I'd appreciate it because that's the biggest complaint that I hear on a regular basis.
Thank you.
With that, I do have in front of me a copy of an audit, a Part C audit that was done. It's dated January the 2nd. It has a number of indicators in it. I'm not going to call out the community provider. I don't believe that would be appropriate at the moment because I'm sure you've received this and you understand. But I'm concerned about some of the program performance numbers in the 50 percentile, 60 percentile. I don't believe that's what we want for these children. And I'd like to know what corrective action has been taken since this is dated in January. And here we are in March, and I just have concerns of this cultural shift that you're looking at when we have these types of problems right now. I think we need to have a clean system before we start to change it, because otherwise more children could get caught in this. So if you could update us on where we are on this particular audit.
Jane Gruner for the record. In that particular case, the provider has corrected the problems that brought about the complaint and has done additional training for the staff and has gotten a clean bill of from Part C to be able to go forth and continue to do business. So the staff have been trained and they have updated all of their program manuals that they use for their agency.
And are we monitoring on top of it also to make sure that there's no slippage backwards?
Yes, we are. And in addition, during this period of time between when our quality team is up and running and able to come up with the 10 quality measures, we will have an interim quality assurance team that will be working with any provider that has a complaint.
Thank you. Dr. Green, did you have something?
Madam Chair, for the record, Dr. Tracy Green. I would have great concern if we don't make some changes, because what we're left with if we do nothing is Part C's ability to audit as they do only. We have no process currently for complaints. We have no process currently for quality assessment. We have no process currently by which we follow and monitor. We have no standardized system by which we are the oversight. So if we sit back and just say, we're at a point now where we should not change or we should not do, then I have these great concerns that we are going to leave Part C as the only entity. I mean, one of the reasons that I believe we are where we're left with this kind of an audit is because we currently don't have a system in place where we have an implementation process where we do regular oversight, where we quality assess ourselves on a regular basis or any community provider. We rely on the after Part C quality assessment. That is our standard right now. And I really think that the change needs to occur simultaneous with what exists with Part C, because to not do that, I have great concerns that we are going to continue to look at complaints like this and ask ourselves, how did we get here when we don't have a monitoring system in place to either prevent and or know we're heading down this path in the future? If that makes sense.
Well, we won't get into a debate right now, but I don't think one precludes the other. I believe both can be done effectively.
Absolutely.
So with that, any other questions from the committee? Let's get into the decision units, if we can, please.
Madam Chair. For the record, Janet Murphy, Deputy Administrator. The first decision unit that we highlighted was our base decision unit. It continues funding for 170 positions and associated operating costs. Majority of the funding increase in our base decision unit is due to analyzing personnel costs for furloughs, merits, and longevity, as well as annualizing caseload. Our next decision unit is M200, which requests the caseload growth. This request funds services for 3,255 children in 2014. That's an additional 316 children, and 3,626 children in 2015, which would be an increase of 371 children. And with that, I'll take questions if there are any right now. Unless you wanted us to just
How about if
continue.
we just flow through and then we'll come back and ask questions in different areas, otherwise
Okay.
we may not make it. So
Okay,
let's just
you
get it
bet.
all on the table and then discuss it all.
Okay, you bet.
Okay?
Jane Gruner for the record. Our next decision unit is E225, a request for autism assessment kits. This request funds Autism Diagnostic Observation Schedule 2, otherwise known as ADOS. The assessment kit's protocols and staff training packages. The newly released ADOS 2 is a standardized assessment appropriate for ages 12 months to 30 months and provides diagnostic information and appropriate program planning for young children. Next unit, E226, requests 8 iPads used for rural case management services, coordination, and interpreters. E710 requests replacement IT hardware and software in accordance with the Enterprise Information Technology Services recommended replacement schedules. E804 provides cost allocation for early intervention services to Aging and Disability Services Division. E805 reclassifies an administrative assistant 4 to an accountant technician 1, an accounting assistant 2 to an accounting assistant 3, and a clinical social worker 2 to a management analyst 2. E930 transfers a clinical program manager 2 from Sierra Regional Center budget account 3280 to early intervention services budget account 3208. And with that, we end our deck units.
All right, thank you very much. I know there are a number of questions that we have on a number of different issues. I think we probably should start with, probably with the elephant in the room is the community providers and the change in that, how you plan on moving forward with that. Are there any questions from the committee on that? Mr. Sprinkle?
Thank you, Madam Chair. Starting right off the bat, I'm just curious at a target of 75% community providers. Do we have those services? Are we going to have that within the next 2 years? Are we going to have that many providers? And if not, are there plans in place to attract them? I don't know, coming out of school, or what are we going to do with that?
Jane Gruner for the record. We currently have maybe almost too many providers in the north, so I do not anticipate that finding providers as a group will be an issue. I think part of our problem right now is that it's hard to sustain a business unless you know that you're going to have certain number of consumers coming into your business. This will help balance out, assuring providers that there are going to be a significant number of individuals that will be coming into their system, while at the same time allowing us to do the oversight that needs to be done for our providers.
For the record, Dr. Green, I just wanted to add that the services that are delivered by the community providers currently are primarily the OTP, occupational therapy and physical therapy services. Primarily, there are some of the specialty services. So in reference to Jane's comment about there being a supplement or a surplus of some of those community service providers, they currently are not providing the services that I was speaking of that we are in great shortage for. So when we are referring to there being a gap in some of the service types, there are specialty services by which we do have gaps in services, and you'll notice in some of the services children are waiting for. And so there is a margin between what we have an excess of in those community providers and what we will need to train up to and or get additional numbers of, those being specialty services that we do think with training, with recruitment, with affordable care, with the pediatric community coming on with the School of Medicine and with other resources, we can meet those 75 numbers. But I think it gets a little confusing when you hear that we have an excess of community providers, and then I just said that, you know, we have a shortage of certain providers. So I hope that maybe clarifies it a little bit.
Okay, Mr. Sprinkle?
Thank you, Madam Chair. It does and it doesn't, because I look at your numbers and I understand that some services are provided while others are lacking. And like I think it was page 6 of your previous thing when I was looking at your slides, the number was still 481. Certain services were not being provided, or there was a backlog, or there was a waiting list, if you will. And then on top of that, what I think I just heard is we're doing okay up in the north, but maybe not so much in the south. And obviously we need to be looking at this from a statewide basis. So I guess I still have concern as to how we're going to be able to meet that 75% goal that you have, and still be able to provide the services that we're trying to get, so that we don't have 481 waiting, so that, you know, the kids are getting what they need. So
for the record, Dr. Green, I think we're kind of looking at two different issues that are, when we look at the waiting list, there's a number of other confounding issues. One of them is moving money to be able to provide the dollars to support the community providers that are actually waiting to provide the services. So we have an artifact of the ability to move some of the money that we're waiting to do a work program on. So there is some fiscal issues surrounding moving money to provide the services for the children on the waiting list, in addition to hiring some of the positions to provide the services at the state, as well as the community providers waiting to receive the children. So one of the elements that is not a problem for the children on the waiting list is we do have community providers waiting to receive the children. So the waiting list has a number of elements to why the children are on the waiting list. In a separate situation, whether we can refer children to the community, looking at community provider numbers. We do have community providers in the north and the south. Again, reaching that number of 75, we do have community providers. It will be that specialty segment. Can we get community providers trained to that specialty segment? We think we can get to that specialty segment of training. We have the basic level of community providers, and we believe we can enhance those numbers to provide those specialty services in the next 2 to 3 years.
thank you. So I appreciate that, and that does help clarify some. Out of curiosity, how long are some of these waiting lists? I mean, how often, say over 30 days or something of that nature? How long are these kids waiting for some of these services?
Ellen Richardson Adams for the record. Based on the slide that was prepared, it breaks it down by specific business along with specific services. Everything that is recorded on that page that was as of January 2013, those are all children waiting over 30 days. I can get you that average wait time if you would like follow up on that. And if I may help clarify Dr. Green's statements, because I saw some looks of confusion. When we talk about community providers, I think we're intermixing a term. So I'm going to step back real quick and help clarify that. So when we talk generally about a community provider, we're talking about a business, and you'll see them listed in the PowerPoint, TMG, Easter Seals, Positively Kids. They're a business that provide comprehensive services, which means that under the contract, they are required to provide all services, speech, OT, specialized instruction, case management, and the list goes on. And then in the same sentence, we're also saying community providers providing specific services. And so if we could call them specialists, that would probably be a lot easier to make sense of. So when we look at nationwide shortages, it's typical that there's nationwide shortages, especially in pediatric, say feeding specialist, occupational therapist, speech and language pathologist. And so as a system, it's difficult to not only hire somebody that has that experience, but also that specialty in pediatrics. And so for some things on the waiting list, it is due to more shortage of that specialty area. But when we talk about a community provider, and Dr. Green had mentioned that, or Jane, I'm sorry, that maybe there was too many in the north, she was talking about a comprehensive community provider that was providing overall service. I hope that helps. Thank you.
Senator Smith, it's all yours. You've been waiting very patiently. I'll let you take over from here.
Thank you, Madam Chair. I have a few questions, if you'll indulge me. First, I want to go back to sort of the overall issue of the budget and the funding. Dr. Green, I think I heard you say that this isn't about the fiscal need, but I think we've been talking for months, and our information shows that we can't clear the wait list without over $5 million. So would you clarify your statement?
For the record, Dr. Tracy Green, it seems that, and again, we've cut through the numbers a number of different ways, and it seems that looking at what is the current work program and the money that is available and is proposed in the 14-15 budget and the current waiting list, it appears that there is money to take the children off the waiting list and not have a future waiting list. And again, you know, Janet, do you want to speak to?
Janet Murphy for the record. Let me speak to how we develop the caseload projections. We utilize a model in our director's office that takes into consideration the wait list, and they run a model through. So I've never really sat down with them to see all the components, but it's comprehensive to project out what we'll be serving. And so we use that. We feel very comfortable with the cost rate that we're utilizing in the categories. So we feel that we'll have sufficient funding to serve the children. It's, as these individuals have indicated, it's more of access to the services and individuals that can provide that.
Okay, well, I'd like then some considerable discussion with our staff, because I think we're pretty far apart the way I understand it.
on this topic. So we have a lot of work to do, I think, in that regard. And I think part of what troubles me is everything we've heard in the past several months is that it's not necessarily cheaper to provide service through the community provider. And so I can't figure out how we're going to clear that wait list. But I really want to have sort of a bigger discussion about why. I feel like we've sort of been dancing around this for almost a year. When we started this discussion, I believe last maybe June or something in IFC, and we were looking toward you coming back with a work program that had a pilot program, and then that didn't materialize. I felt like we kept sort of moving toward what you are proposing here, and then we didn't. And now we're back there again in a much bigger way than what I thought I was hearing in our past discussions. But I'd really like to have the bigger discussion about why. You know, why do we want to move 75% of our service to the community providers? And I'm not judging good or bad. I want the bigger discussion about, you know, very explicitly why it's a better model. And then I want to hear what that leaves our current staff doing and, you know, what those jobs look like. I appreciate the fact that we're not eliminating positions, but are we leaving people who are talented and capable of serving our community, our constituents, with, I don't know what they'll be doing if we're moving 75% of the business out of that agency. So I know that's a lot to ask, but I feel like, you know, really the elephant in the room is, why are we doing this? What's the reason behind this huge shift?
For the record, Dr. Tracy Green, I can touch on that. I think that there could be a philosophical question as to what is the state's role, and if there is community capacity, is there the opportunity for the state to be the assurer of the delivery of services and the assurer of quality service delivery, and to be the safety net for those children who are unable to receive services in the community, so that essentially the state becomes the quality assurer. They become the quality assurer. They basically are the state role is the overseer, the one that allows for all of the systems to be assessed. They become the experts. They become the technical providers of education and oversight. But also, they are providing any services by which the community capacity does not exist, with the intent to train the community to become capable if that option exists. So again, if we can hire a metabolic specialist with the hope that we can support the university and private practice to develop a system by which the state can then deliver the services, is that a part of this role where then community capacity exists for those services to be delivered? And ultimately, we are always there if a child does need services. We are there with staff that can deliver services as a fail-safe for all children.
And maybe that's part of my point, is if we are the safety net, then why are we shifting 75% of the services out? I think that's part of what troubles me. And especially if it's not a huge financial benefit. And I sort of feel like this morning I haven't heard it directly, but I sort of feel like that we should be providing work for community providers. And I don't think that's our role, is to assure that you know, and I appreciate the work of the community providers, don't get me wrong, but I'm not sure if I think that's the state's role, is to make sure they have all of the work or all of the business they need. And so I need a little bit of reaction on that, I don't think that's our role. But again, if we are providing the safety net, but we want to shift 75% of the services out, why? Why don't we be our own safety net in a bigger capacity than only 25%?
Jane Gruner, for the record. My intent was not to appear that we think that we need to help fund our community providers, but that for community providers, they're able to hire and much easier than the state is. Currently, we are unable to find people, certain specialties to work directly for the state because they make more generally in the private sector. Our community providers are actually able to hire people to work for them much easier than we can. That is part of the business model that pushes us forward to maybe want to access that ability that we currently do not have with the state. And I think that that has helped drive that forward, that we really want to use the state staff that we have because they're wonderful. For the most part, they're absolutely wonderful. And we're going to use the staff for that specialty area and to help our community providers have the same kind of quality. They'll be in working with our community providers. They'll be working with individual cases. So if there's an issue, that quality person is going to be at the table with our community providers, and they're going to problem solve the issue and figure it out and help the family go forward. So I think it's really more of a hybrid issue that we're talking about. How do we use both to the best for every child that we have in Nevada that's using this system?
Okay, I'll stop for now and let someone else, as I ponder this. Thank you. Thank you very much.
I believe I have Senator Kickhuffer and then the speaker, so Senator.
Thank you, Madam Chair. And if, with your indulgence, I'd like to sort of speak to Senator Smith's question as well. And the way I envision this is the following. NEIS serves children who are 0 to 3, and when they become age 3 in a day, their needs don't end, and we need providers within our community who these children can still access, and utilizing NEIS and the $30 million that we're going to be putting into this program to build community capacity is good, not just for the kids who are 0 to 3, but for children throughout the age range who are going to need and utilize services as they continue to grow and continue to need developmental services as they go forward. So I think leveraging what we have available to us to build community capacity as a broader community benefit for families with children of all ages. And that's sort of how I see the benefit of switching to a more community-based provider network. So I'll stop pontificating, I guess, and ask a couple of questions. So when we do shift a child to a community provider, and I think it's important to realize that, right, and you tried to talk about this, that there are really 3 categories of people. There are state employees, there are individual contract employees, and then there are more comprehensive community providers. If we put a kid into a community provider system and there's a wait for a service from that community provider, can we shift for that service to a contract provider and then deduct from the cap rate that we pay based on the cost for that individual service?
Ellen Richardson Adams, for the record. That is possible. We have not done that, in all honesty, but that is something that could be looked into, and it would definitely, I guess, address some of the concerns with that.
Okay. Thank you. And then I think Senator Smith was leading to a question that I also had, and I don't fully understand if we're currently serving about 50% of our our youth with state employees or developmental specialists in a lot of cases, or service providers directly, and then we shift, half of that workload out of their purview. What do they do at that point?
For the record, Dr. Tracy Green, there's an element right now that we don't have, which is oversight. And so currently, our team of workers that are our developmental specialists, what they are not participating in is the oversight of both ourselves and community providers. And so what we see is where we traditionally have where we traditionally have our employees participate in the actual development of the IFSP, what we will now have is our employees participating in assuring and analyzing and reviewing what the services are they happening in a timely fashion, are the outcomes appropriate. So now our staff is actually becoming a part of that team for the child, but they are representing the child to assure that the services are being delivered. So they are taking a oversight role, oversight part. Maybe Jane can do it a little bit better.
They will be the quality piece that brings back providers are doing a great job, providers needed additional help, and what kinds of help that is. It's those red flags that if you see them early, you can make changes to the programs to assist the provider to deliver the best services possible.
Senator? If I may, Madam Speaker, right before just because it's right off the Senator's remarks, but is that what a development specialist does? That doesn't seem to be what their job is. Their job is something else. So we are, in essence, changing their job classification.
Jane Gruner, for the record. They will still be part of a team, and they will still be problem solving to bring about the best quality for the child and the family.
But they will not be working with the child, and currently they work with children, correct? I just want to make sure that I understand.
Well,
all the
they are part of the
dynamics.
team. They will not be delivering the direct service.
And then currently to now, they do deliver some direct services.
Part of the people will not. The people that are continuing to work on the medical side, where they stay with the state, they will still be doing direct service.
Okay. This is, I mean, we don't work in this world, so we just want to understand where all the divisions actually work. Madam Speaker, sorry to keep you waiting so long.
No, I'm glad that you clarified that. I questioned this at the IFC meeting that I was at when we were trying to hire the person outside of the scope of IFC, and it was hired anyways. There was other monies that found, so I know that you guys are pretty creative in how you want to get things done. But what I'm hearing today, and it's somewhat frustrating to myself, is that it seems that we're taking our state employees, changing their entire scope of what they hired onto to benefit another group of folks to do their job. So I don't understand how we're saving money, because you haven't made me believe that we're saving money as much as we're spending more money to make sure that our community partners are up to par, changing our current state employees to different positions. And at some point, I mean, there's not even, I hope within your quality assurance, there's a process to go back and make sure that, and we looked at this in 2009, that sometimes the community services were costing us 3 times what our state services cost, and no one ever really addressed it then. And so here we are back trying to do the same thing in just a different scope. And so I'm not understanding why, none of it makes sense to me. And I don't know that I could explain it to one constituent if they ask why everything had changed. 75% of the community centers, which we know some of those things are good and they're helpful to have wraparound services, but I don't hear you guys talking about that scope as much as changing everybody to fit a model that neither side has at this point.
Jane Gruner for the record. One of the issues that continues is that we do not have enough developmental specialists to see all the families. If you look at the wait list, that's the number one service that people are waiting for. And by spreading it out, by having providers that have that, we should, once we can change some of the money function around, we should be able to get many of the children seen, because the they can hire more developmental specialists to see individuals than we can as a state entity, without asking for a significant additional number of positions.
So, Madam Chair, if I could follow up. So then let me ask this question. For the long-term vision, then what are we doing to create more developmental services? Yesterday, we heard that they're working with the workforce boards and making sure we get all those people, because we are doing that, but we're helping a private community group get that development services instead of creating our own within the state. You're looking at me like I have four heads, so apparently I need to restate my question. What are we doing? It sounds like we're just pawning off this service to somebody else, but yet we're helping them do all of the training to create those development services people, but we're not helping ourselves on the state level to create those for the long-term vision, because this problem isn't going away tomorrow. It isn't going away in 5 years, and we're always going to have kids on it. But what are we doing on the state level to ensure that we're creating that workforce? Right, because that's part of the governor's workforce board. That's one of the sectors. But I just hear that we're going to spend a lot of money in another direction rather than trying to create our own and bring people along.
For the record, Dr. Green, we are doing things from the physician side for enhancing our physician profile, in that we've expanded our physician role at the state, and we are expanding. We are going to continue to provide 50% of the services through at least the 2015, and then as we move to the 75, again, we are still going to have 25% of services. And in the budget, those advanced ADOS for autism training, that is to train our staff so that we get autism specialists trained at the highest level. We are enhancing the training profile for our staff, so we bring in at the first step, but we do train our developmental specialists. So although we hire at the first level, we do offer extensive training within early intervention. So again, we're trying to bring in the first level developmental specialists and continue to offer them extensive training so that they get the full gamut of training and ultimately become trained specialists. So from the enhancement side, we are working with our specialists and attempting to recruit those specialized providers as well. And then from the physician side, we're working with the School of Medicine. We're training residents at both of our facilities. We've expanded our medical doctor to both full-time positions. We're not going away from the service delivery model, but we are looking at ourselves as what are the services that the community is not currently able to provide. Hopefully
Can I just ask one last question?
I think you're trying to get to capacity is a good word for you.
Okay,
Madam
good.
Speaker, you're looking for capacity of workforce, and I don't think we're quite getting to the answer you're looking for. So, go ahead.
And so I'm hoping that at some point we get that answer, because it's an important answer on the vision of the state for the long term. So where does the liability lie when we shift to this newer model? So is the state still liable if there is a parent that feels they have a complaint and there's a suit that comes about because of a service that was provided? Are our community partners exempt from that liability, or is it all fall back on us?
Jane Gruner for the record, it is a shared liability. And we are the people that they will come to with the complaints. It is our responsibility and our job to assure that people providing services have a high quality.
Okay, thank you, Madam Speaker. I think we have a few other excuse me for my voice, a couple questions we need to get through, and then I was planning on taking public comment on this and then moving into the other health division budgets after that, so that we can try to stay somewhat close to the schedule we thought we were going to have today. Anyway, but this is all very good discussion, and we need to understand what's going on. It's very important to these children. It will be whether they succeed in life or not. So this is much more important than the schedule. I'm concerned about the medically fragile children and what's going to happen there. I mean, what it takes for those children to succeed it's just almost a miracle every time that it works. So can you talk to me a little bit about the medically fragile children? What percentage of those children? How do we plan on, wrapping our arms around them and making sure that they're taken care of?
For the record, Dr. Tracy Green, at this point, our current track system does not accurately assess the number of children that are quote-unquote medically fragile. We have begun to look within the system, and we estimate that approximately 40% of our children are what we have chosen to designate as medically fragile. Those are those children that require more intensive medical assessment and services prior to what we believe is the ability to receive educational and or developmental services exclusively. I believe these are the children the physicians were extremely concerned about. They're the children that are being referred directly from the NICU with very high medical needs. In the system, they will be addressed immediately in that they are so critical that very short periods of time could result in some instances, death and or, very life-threatening events. They get immediately entered into the system, and they immediately see one of our physicians. We have 1.5 full-time physicians in the south, and we have 1 full-time physician in the north. The physicians do their initial assessments and determine what their primary needs are. They are involved in their IFSPs, which is essentially their plan of services. At that time, we really then determine whether they qualify for any other services other than the direct medical services. And so in the short light, that is the span of the life of that child. For the immediate sense. We also are working with the community providers, and I shouldn't say community pediatricians. Each of those children need to be attached to a medical home. It's something that we had not previously focused on that now must be a focus for each of these children. Some of them have just the birth physician as their medical doctor. They all need to be referred to a primary care physician and or pediatrician as their medical home. So that is the other step that is occurring in early intervention for these children.
Now, there is a NICU team in the north, correct?
Yes, there is.
And there will be a NICU team in the south. When do we plan on that happening? I'm just assuming there will be.
Ellen Richardson Adams, for the record. Currently, the Southern office has a MOU with Sunrise Hospital. There's multiple NICUs in the southern area, and so it's been more difficult to set those up. But we do have really good working relationships with the different NICUs, just not necessarily formalized MOUs. I'd like to move to that place and to get that more established across the region. And in addition, our physicians contact and speak with whether it's the referring physician and or their current pediatrician.
Okay. Thank you. Other questions from the committee on that? Yes, Mr. Spring? Not on that? On something different? Okay.
Thank you.
Thank you very much. I just want to make sure, and we're setting up the procedures to make sure that everyone does talk to each other and things do get expedited quickly for these children. So, okay, good. That gives me a little sense of comfort on that one. Mr. Sprinkle, you had a question.
Thank you, Madam Chair. I wanted to talk about the caseload ratios. again, looking at moving to the 75%, what's that going to do to the ratios with the employees that we do have now? I'm just wondering if we do get to this place that we're looking for by 2015. I would assume that the state employee caseload ratios would go down, and then consequently, my question would be: do we still need to maintain the workforce that we have?
Ellen Richardson Adams for the record. If we're really looking at going to this next service delivery system, there would be a couple components to take into consideration. One part would be establishing appropriate ratios for the community providers, and that's what would fall with the quality assurance. Currently, based on the provider agreement / contract, it's not stipulated in there. And so that would be something that would be built in along with the quality assurance component. By utilizing the current developmental specialist, the state employee, we're looking at a unit. We're not saying all developmental specialists on the state side are going to become this quality assurance part. What we're saying is there'll be a unit of developmental specialists. And really that's advantageous for the state because, I was a developmental specialist. I love my job. I'm also a parent of a child that was medically fragile, so I appreciate you speaking to that. It's a lot of work. It's, the relationships that we build with families. In essence, we become part of their family, and we have a high turnover rate overall. Now, we have people that have been in the system a long time in terms of employees, but overall, it does have a burnout component because of the nature of the work. And so this ability to look at this next step of service delivery is we have the utilization of keeping those state staff and really utilizing their expertise and experiences to help train and oversee other cases so that those children that we just talked about have that safety net. They're able to ensure that children are getting appropriate levels of service. If we see, for example, occupational therapy one time a quarter and the child has multiple delays, that's going to warrant, talk to me more about that. How did you guys come to that frequency and intensity of service? Because of my experience, I know that's probably not appropriate levels versus somebody who maybe is just coming off and into our developmental specialist world. The other part, too, looking at the caseload component for the state employees, looking at the medical children that are medically fragile, really providing them maybe like a 12-to-1 caseload ratio where they can really provide those intensive services for a smaller amount of children. Currently, we're budgeted for 25-to-1, and so the 12-to-1 would really allow for them to provide those specialized services, service coordination, specialized instruction. We know research-based that children birth to 3 and up to birth to 5, that's our time when we can really make an impact on their brain, really help teach them the skills that they need for success. And so by having those higher frequency and intensities, building those relationships with families, empowering families to learn how to do the strategies themselves, we're going to see longer term success.
Thank you, Madam Chair. So what I heard was, yes, the caseload ratio should be going down, that we won't technically be losing positions because you're going to be, in essence, reclassifying their jobs. They'll be doing more oversight. And so then that gets me back to, I think, some of the questions you've heard before. I don't understand why, if people chose to go into this profession, went through all the training and education to get to the place that they're at now, why you feel that we're not going to continue to have large turnover, why these individuals wouldn't want to go to the private sector. As you stated earlier, they could potentially get better pay and benefits. And so my ultimate question is, have you actually had this conversation with your staff, and are you confident that they're comfortable with this change in their job?
Ellen Richardson Adams for the record, and I'll speak on behalf of the southern region. I have spoken with some of the staff. It does provide them an opportunity to still utilize their skills in a different capacity. When we look at the developmental specialist series itself, the state classification, it still does fall in line with the scope of work. And so, it's not going to be you and you are going to be part of this quality assurance unit, and you are going to, have a caseload. We're really looking for the staff who want to help build that quality assurance unit, and then they would have the ability to go back to serve those caseloads as well. And so, and that would help serve the staff retention component, because if they're able to, quote unquote, take a break of that direct service time, then they're able to still utilize those specialized skills and trainings that they've gotten. And then, 2-3 years down, whichever, they would have the ability to go back to a caseload if needed, if that's what they're wishing to do.
Okay. Senator Smith, since you stopped earlier, did you have anything else you'd like to address before I get into a couple final questions, and then we'll go to...
No, you can go ahead.
Okay. As far as the possibility of cost sharing, have there been any discussions with the community providers? I know it is in the NACs that you are allowed to bill private insurance for services or do a sliding fee scale. Have there been discussions along that line as we move towards this community provider model, if that will occur? This is the Ways and Means Committee. I know we've been acting like a policy committee today, but this is so intertwined that it all works with each other. So I really do need to ask a money question to validate my job today. So.
Ellen Richardson Adams for the record. Currently, the state's policy is the cost should be at no cost. Services should be at no cost to the family. We have explored the sliding fee scales in the past of, the parents providing some cost sharing in that. Currently, there is an ICC subgroup that's looking at all those options and what would it take to get to that place. Nationwide, some research that I've done is some of the states have gone to that, and it hasn't necessarily yielded the results that they were looking for. Some states it has, but other states it hasn't. One thing that they're looking as a variable at this point is the Affordability Care Act, and how will that impact the sliding fee scale. Some states have seen where families have disengaged with some of the services because of the cost sharing. That's some just information that I have at this point. One thing we've looked at in terms of this overall model is some of those access abilities. All children in the system, not just kids in the state system, but all children in the EI system would have the access to the pediatricians, to the audiologist, the dietitians, et cetera.
And we always want to make sure of that. We don't ever want to limit access based upon ability to pay. It's not what we're talking about. It's just if there is private insurance available and there is an option to help cover some of that, I mean, that's what people pay their premium for, is to have their insurance. And if it's part of the policy and it can be covered, but also we want to make sure that if that does happen, we've heard before, do we have the ability to bill? Do we have the ability to adjust rates depending upon billing? Because the last thing we would want to do is to give a community provider the opportunity to bill through the state, but yet still get that full capitated rate when there is an insurance premium or a reimbursement out there. So I think that's something that has to be part of the mix as we move forward in this discussion, if we do try to work with all these children, get this done. So other than that, I think we've covered a lot on EIS. We've had a lot of other questions too, but I think we've touched upon them in most of the conversation that we've had. So I'll open it up to the committee for any final questions that they would have of you, and then we will go to public comment. So, thank you very much. We appreciate you being here, and I'm sure we'll be doing a lot of follow-up and discussions with you. Thank you all. It's a pleasure to work with you. So with that, we'll go ahead and start with public comment on this. I do have, I believe, some folks signed in. Let me see what we have. These usually don't do sign-in sheets on this committee that much, so I have to remember how this all works. I believe we have Dr. Coletti that signed in to speak. Did you want to speak, Doctor? Well, come on up. Don't stay. Well, no, I'm calling up a whole group of folks here. Actually, if you signed in, please come forward and just sit down. Don't wait for me to call your name because these sheets don't necessarily benefit. I think I had Mr. Uriarty had marked in. Mr. Burns, I think you had marked in that you had wanted to speak. If you'd like to go ahead and come on up, please go ahead. If you didn't sign in, that's okay. We'll take care of it afterwards. Go ahead and come on up. Mr. Patchett, I think you had signed in too, so when there's a seat available, we'll go ahead and have you come up too. So please keep in mind, we are on just a bit of limited time, so if you would keep your remarks succinct, and if someone has made your statement earlier, just say "me too" and then put a couple extra sentences in, and we'll go from there. Doctor, I'll have you go first.
Hi, I'm Dr. Pat Coletti. I'm representing 75 pediatric providers in northern Nevada, and I addressed the committee before a few months ago regarding basically the same topic, but now that we've moved forward a little bit on the idea. So basically, my role in life is the big picture role, and so I've been pushing all these people about the medical model as the evaluating model for NEIS kids, because despite what numbers you might want to call medically fragile and non-medically fragile, all of these kids have serious medical issues, or else they wouldn't be involved in NEIS in the first place. So these reasons are not always purely medical. Some of them are social, financial, cultural, nutritional, and the lot. But my training, and which comes from the developmental team at the University of Iowa, the first premise of education in all of these kids is that you got to have them come to the table with a full plate. So if you have a medically fragile kid at any level and you put them in what some people call a purely educational or developmental program, we always look at those actually as partially medical anyway, because those kids all carry medical diagnoses, and they are not ready to be there. They don't learn, and then they fail. And so when they do fail, then you got two problems. You got a kid who has to recycle, and you have a burden on the system, but you also have a lot of disappointment and maybe even a lifelong problem with these kids not being able to get to the level of being able to sustain themselves in the society, which is, I think, the whole idea of early intervention, is to try and get them there. For my part of it, I wanted and pushed very hard for the initial medical evaluation, because all of these kids have something medical going on which will interfere with their educational abilities. And if we get those out of the way, some of them can be got out of the way quickly. Some of them are chronic illnesses that don't get out of the way quickly, like the kids that come to special children's with on a vent still from the NICU. Those kids are going to be medically fragile for an indefinite period of time. Fortunately, a lot of them may have things that can be fixed fairly quickly, and they can get on with their speech therapy or occupational therapy. The step that I proposed was to have that complete evaluation, and then the things that have evolved since that time have been how do we complete the circle. So, Dr. Green alluded to the fact that some of the medical practitioners in the state do not formally refer but just tell parents we have to fix that system and create a kind of a universal way of getting these kids there. We also need to very strongly look at what happens after they go into the system of the educational part, and that was when we were talking about the QA, which I brought up at the last meeting, which it didn't exist, which shocked me actually at the time, because in medicine we're just constantly bombarded by QA. Because if you put a child into an educational system, you got to measure him before he goes in and you got to measure him before he comes out, and if he didn't make the progress that was alluded to, then you got to figure out why. And if it's the quality of the provider, that leads to one line of change in the system, and if it's the quality of the program, or maybe the child was more complicated than we thought he was and needs to go back through medical. All of these things have to be on the table when someone's trying to manage the system from a medical model perspective. The other thing that I wanted to allude to quickly was the privatization issue. The pediatricians have not been keen about the privatization issue because of some of the problems alluded to with no QA, and we don't really know how good these people are. And so the other thing is it's quality, not quantity, and I think bringing more privatized developmental people into town without knowing what their qualifications are is not necessarily an easy fix. So I would have to say that if 40 to 50% of the kids entering the system are medically fragile, those kids are probably not, many of them, going to ever be reasonable to send to a community provider because they have such horrible problems. And I think that for that reason, that the central receiving at NEIS is going to have to continue to be robust and well-trained people and enough of them to get the job done. Thank you. Any questions, I'll be happy to answer.
That's fine. Thank you very much, Doctor. Does anyone have any questions of the doctor? Yes, Mr. Hamburg.
Thank you, Madam Chair. Doctor, kind of a touchy question, so I'll apologize up front, but I find it a little disturbing that you would question the qualifications of some of the community providers. It'd be very much like I challenge your qualification, even though you're board certified. Some of these community providers have national certifications.
That's
then would you then not recognize those as
oh, yeah,
you
we recognize your
your
certifications, but actually, when you ought to come to a pediatric department meeting sometime, we're challenging each other right and left, and they're all the same people. It's not a challenge of a negativism. We just want to say, okay, this is a problem. How did you present solving it? It didn't work out. What's your solution? And then if they don't have a solution, that's when the discussion starts.
Follow on, Madam Chair.
I don't want to get argumentative with a
level.
witness under public comment.
I will not
That's
be argumentative.
really
No, so it's a communications questions more than a qualification question.
Right. A lot of times,
communicate.
a lot of it sometimes it's the perspective of the person
Excuse
entering.
me, gentlemen.
Oh.
I think it's done.
Oh, okay.
Yeah. Thank you.
Thank you.
Thank you.
I appreciate that. We usually don't get into too much comment under public comment. We let the public, and then if there's any clarifying questions, we'll make sure that you understand the comments that were made. We don't want to get into an argumentative situation. I'm sure that's not where it was going to go, but we just didn't want it to get there.
I have no problem with.
Thank you. Thank you. And you gentlemen are more than welcome to duke it out in the hallway. So, I think that you can use my conference room. You're more than welcome.
Great.
I just didn't want to go down the wrong path. The young lady that had not signed in, if you would just please introduce yourself for the record and please spell your last name. And then when you're done, if you would give your information to the secretary so we can make sure that we can include it in the record.
Okay.
Okay? Thank you.
My name's Tamara Ariano, and it's Arellano. I'm just a parent of of 2 children. One child that's 8 has already gone through NEIS services, and I'm just supporting the governor's request for a budget increase. And now I have a 2-year-old that's with NEIS, and my biggest concern is the wait list. If there's this huge wait list, it would just appear to me that there's not enough providers with NEIS. So as a parent, I don't care whether I'm seeing a therapist with NAIS or one in the community. I just feel like all the children need to be seen. And I'm lucky because my 2-year-old is being seen. But, so I'm just supporting the budget increase. And I didn't know that there was all the political stuff going on with it.
You wouldn't think it, would you?
But as a
no.
parent, I don't care who my child is seeing. They just need to be seen, and as soon as possible, because I think their little brains are sponges, and the sooner they are seen, the better. And I've seen a huge difference in my 8-year-old, and already seeing a difference in my 2-year-old, who's been receiving services for about a year. She wasn't even crawling, and now she's walking. So.
Well, that's great.
So
We're glad
it
to hear
really
that.
is important. So
That's very good.
and
Thank
that's
you.
all
We appreciate you being here
Thank you.
as a parent. We do. We appreciate that very much. So, Mr. Bobzian.
Madam Chair, if I might, I think that was probably the most sensible thing I've ever heard uttered in this building.
And believe me, you're not just a parent. You're the person that we're working for here today. So
Thank
we're
you.
we're all just parents. We can all come from it from that point of view. The last time I visited a NICU unit, I thanked my stars that I had not had to walk through that unit before in my life. So congratulations and good luck. And thank you for being here.
Thank
We
you.
appreciate it. Thank you so much. Mr. Uriarty, and then Mr. Burns, Mr. Patchett, if you'd like to go ahead and come on up.
Excuse me. Madam Chair, committee members, Keith Uriarty, Chief of Staff, AFSCME Local 4041. And I have submitted testimony to the committee, and I'm not going to go through that other than to highlight what we all have been through, and over the last almost year. And excuse me, specifically even the Executive Audit Committee, and I have on the record of even questioning the validity and the integrity of that audit as it relates to the costs of EIS and the change in that model. And then also, I mentioned, and it is attached, the Part C audit, the most recent Part C audit, that is January 2nd. And if I may, and I would just, for reference, like to just read a couple sentences from a previous legislative session. And it is the minutes of the Senate Committee hearing on Health and Human Services, April 4th, 2011, and it was regarding Senate Bill 382 that was to establish provisions relating to early intervention services for infants, toddlers, and with disabilities. And I just wanted to read a couple of sentences, excerpts from some testimony with regards to that particular legislation. There is, and quote, there is the Nevada Early Intervention Services, NEIS, which is providing early intervention services for about 16,000 children. Then you have community providers such as ESDS, Easter Seals Developmental Services, Therapy Management Group, and Positively Kids that are providing services to approximately 900 kids. You can choose one of the community providers to serve the child. Those who are being served by the state do not necessarily have that choice. We would like to provide the family with the best choice for their child. The intent of this bill is to give parents that choice, and through that bill, a better system. The last sentence, I should also add that all the community providers are held to the same federal standards, and they are all meeting or exceeding those standards. That is the testimony of Brian Patchett, the CEO of Easter Seals. And in closing, I would just like to say that, as I ask in my testimony, that before there is any approval of this budget, that the legislature conduct a thorough investigation of the entire NEIS program. Thank you.
Thank you very much. Mr. Burns?
Thank you, Madam Chair. For the record, Robert Burns with Therapy Management Group. And first, I'd just like to thank this body for recognizing me and giving me the opportunity to speak before you again. I appreciate that. And I'd like to also thank this body for thoroughly vetting this process as we try and move forward, doing something that, quite frankly, complements the efforts of not only the state, but complements the efforts of parents like the one that just spoke just a moment ago. And I think as a community provider, as one of the community providers, our goal is just simply that, to complement a process that makes sense, not only first and foremost for the parents, but I think complements a system that makes sense for a state that is charged with this responsibility, both to meet its obligation not only to these parents, but to meet its obligation, its fiduciary responsibility to the citizens of this state in providing this service. And I think that, for the record, as a provider, I think that the quality assurance piece is paramount to a system that's going to function with the integrity that this system has to have for it to have any real value for its end user. And I would, again, encourage this body to continue to promote that piece of this puzzle and making sure that it's there, because it makes all of us better, whether the children enter from the state side and stay on the state side or come to the community provider side. They need to be very confident in the services that they're getting. And I think that the only way that we can ensure that is to make sure that the quality assurance piece is there and it's rock solid. I think initially when my business partners and I presented to the health division our proposal, that was one of the cornerstone pieces of it, because in our research, the other states in the union have recognized that the state, since it's going to be held accountable and responsible for these children, needs to be that policing agent, needs to be that entity that is providing oversight, training, qualifying the providers that are charged with providing the services on the state's behalf. And I think without that piece, there's a system that is, I think, diminished in a certain sense. And I would, again, I can't overstate it enough that I think that a very linear, forgive the term, simply complex system that a parent can wrap their brain around is important. And right now, there are so many tangents in this system, and there are so many tiers and levels and strata involved that I think is very difficult for a parent, such as the one that spoke earlier, to navigate through this process. And I think that giving them that clear linear path and giving them an opportunity to voice their concerns and their pleasures with the process is ultimately to their benefit and to our benefit, because it's going to make us better providers. And so more than anything, I just wanted to, again, just thank you for the opportunity to speak, answer any questions that you may have, and then also encourage you to continue to move this process forward in whatever iteration it ultimately turns into. Thank you.
Thank you very much, and thank you for spending the time that you did with us during the subcommittee hearing and helping us understand this issue a little bit, at a deeper level. We were all still learning at the time, and you were very helpful in that, and we do appreciate it. So I think the speakers are allergic to us now. So thank you very much. Are there any questions? Seeing none, thank you very much. Mr. Patchett, welcome. Mr. Lovegren, were you going to make public comment on this particular issue, or was it another issue? Okay, thank you. I just wanted to make sure I didn't miss you. We do public comment? Okay, did you sign in?
I signed in, but I didn't mark that I was.
That's okay. Please go ahead and come on up. I'll have Mr. Patchett go, and then I'll have you follow up afterwards. Mr. Patchett, welcome to the committee.
Thank you, Madam Chair. I appreciate the opportunity to speak, and my name is Brian Patchett. I am the CEO for Easter Seals, Nevada. I've been with Easter Seals, Nevada for 9 years, and with Easter Seals in other parts of the country, a total of about 16 years. I first want to say that I appreciate what the testimony that was given by the folks from the state, who especially talking about some of the things that are being implemented related to the doctors, the physicians. I appreciate what Dr. Coletti said, and certainly agree with what he said, and also with what Mr. Burns has said. I am excited to see that the system becoming hopefully a more straightforward system, and that there is going to be a greater evaluation up front for the kids as prior to entering into what's considered Part C, early intervention. Easter Seals provides early intervention services in the south to about 250, 260 kids, and about 50 kids in the north. And we look forward to that, to continue to provide those services. We look forward to the great success that we see with the kids. I think that as quality assurance is put in place, as we work through this, that we will see a better, a more robust system for early intervention. And I should also point out that as Easter Seals, we do provide some services to some of the kids in rural areas, and that's quite often as much as 2.5 hours away from here, in some very small communities. And we hope to be able to continue to do that. And again, I'm in support of this budget. I think that they're going in the right direction. And with that, I'll conclude my testimony.
Thank you very much. Do we have any questions for Mr. Patchett? Seeing none, thank you very much. Yes, please introduce yourself for the record.
Yes, my name is Corrine Vieweg, and I'm the Executive Director for the Northern Nevada Rave Family Foundation. What we do is provide respite care to families that care for children with special needs. And this is my first public hearing, so I wasn't sure if I was going to be able to speak, so I wrote what I'll be testifying upon. I have worked with young children in the state of Nevada for the past 12 years, many of whom have qualified and received vital early intervention services. It is essential for these children to see in a timely manner and receive qualified services upon eligibility. Children with special needs require far more care, resources than a typical developing child, which contributes to add stresses among impacted families. When a child does not receive the services needed and there is a delay in services, the stress level of the caregiver increases, and the child is at a higher risk for child abuse or neglect, as caregivers' stress levels are a direct correlation factor to child abuse and neglect. Excuse me. As research shows, early intervention is a key to identify and treating developmental delays. Without fully funded early intervention services in the state of Nevada, there will be a decrease in the likelihood of these children becoming capable of performing at the same academic level as typical developing peers. Once they begin to attend school, and the academic and educational climate of Nevada will reflect the lack of the focus that these children and their families deserve. On behalf of the Nevada children eligible for early intervention services, I would like to publicly state the tremendous importance of having intervention services fully funded, as these children are innocent and their families may have the hope, knowledge, guidance, strength, and live a less stressful and brighter future. Thank you.
Thank you very much. We appreciate you being here today. Is there anyone else that wishes to make public comment at the moment? Seeing none, we'll go ahead. Oops, we did? I'm sorry? Oh, sure, come on up. Why didn't you wave at me? There we go, I didn't realize. Can you get to the microphone? That one's okay, too. You just turn that one on, that'll be fine.
Madam Chair, Sam Lieberman for the record. Just to compliment the testimony by Mr. Patchett earlier, Easter Seals has been providing services for multiple decades in southern Nevada. We're very new to this process in northern Nevada, and we would invite you to join us on April the 5th for our statewide kickoff, at which time you'll be able to visit with our parents, our families, our staff, to understand better the importance of these services that we now hope to provide statewide for many years to come. We were encouraged to become statewide providers by many community leaders and by our national Easter Seals, which felt that the previous affiliate, although very much entrenched in the community, was not meeting the needs of the current family units as they needed to do. So our program, which had been solely Southern Nevada-based, has been enhanced to cover statewide in the last year and a half. We look forward to educating you more on the process of what we're doing, and we look forward to serving the needs of the states and the family for many years to come. Thank you.
Thank you, Mr. Lieberman, very much. And please just leave your information with the committee secretary so we make sure we note that you spoke today appropriately. Thank you very much. Is there anyone else that would like to make public comment at the moment? Seeing none, we'll go ahead and close the hearing on early intervention services, and then we'll move into the health division budgets. I'll give them a couple of quick seconds for those folks who are going to be leaving to go ahead and exit, and then we'll move on to the next. And we'll try to make it through as much of these next budgets as we possibly can, knowing full well that we don't think we're going to reach the end today. We'll just find one. That's okay. We knew that was going to happen. Oh, all right. All right, we'll go ahead and open up the hearing on the Health Division budgets. We weren't planning on a presentation this morning. We were? No, I didn't think so. I thought we were good. We were just going to go ahead and work straight through the budgets. And just, we'll open it up, and because the sequester has been such an issue, if you could just give us a brief overview of what you might be seeing on the horizon when it comes to sequestration. We don't want to get too in-depth because we know it's a moving target, but what you might know now would be helpful. So we'll start with that to begin with.
For the record, Richard Whitley. I serve as the administrator for the State Health Division. So beginning then with sequestration. Sequestration went into effect March 1st on Friday. It is a moving target in so much as we know the reductions, and you'll see in this budget, primarily it's there's federal funding through grants in each one, and so we do anticipate impacts. The notifications that we've received are that the impacts are up to 9%. There is to sort of soften the impacts, what we've been informed by the federal government is that we will basically have the opportunity to renegotiate our deliverables as the reductions occur. And so as an agency, what we've done is looked at each grant, because each grant does a different thing. You know, some provide direct services, others do planning and community education. So we've prioritized direct services, preserving state FTEs, and then preserving resources to the community. So as an agency, what we've looked at is our prioritization, but the impacts up to 9%. And as I go through each budget, I'll just give the dollar amount of what that could be up to. But again, like you said, it's a moving target, and it seems to be being managed by individual grants, what those exact reductions will be.
Mr. Whitley, there's one thing that I think we need to probably discuss because it'll come up in each one, well, not each one, but in a lot of these is the maintenance of effort provisions that are in there. If we do lose federal money and by some strange reason we do end up backfilling, if we have the money, what does that do to our maintenance of effort agreements and how are we going to address that?
Again, for the record, Richard Whitley. The direction is clear on that from the federal government, and that is that the expectation for maintenance effort will be reduced based on the reduction in the grant. And so we'll still be expected to, both with match and maintenance of effort, be expected to achieve them, but as they reduce the grant award, we will also be extended that.
Okay, so in essence, it'll be a hold harmless?
Yes.
Even if we do backfill, that will not be included in our future maintenance of effort?
That is the guidance that I've received.
Good, thank you. That gives us a little bit of comfort knowing that we won't end up setting ourselves up for a long-term problem in the future. Okay, thank you very much. So how about if we go ahead and start with the first budget, 3190, Health Statistics and Planning.
For the record, Richard Whitley. This budget account, Vital Records, the program of this budget is the Office of Vital Records, which records, manages, and assures the security of the birth and death certificates in Nevada. The major event that you'll see in this account through the decision units are the program moving from a paper process to an electronic record. That's occurred over the past several years, but you'll see in these decision units the impact of going to an electronic system. Decision units E225, E230, and E805 address staffing for the Office of Vital Records to assist with the management of the electronic records. Decision Unit E227, E276, and E277 address staff training and the travel needs to assist organizations such as hospitals, coroner's office, funeral homes, and the health districts with training. Decision Unit E226, E229, and E713 address information technology and needs for the electronic records. Decision units E714, E720, E721, and E730 address operating supplies and office reengineering needs due to the transition to the electronic record. And then Decision Unit E228 allows the Health Division to retain the fees received for vital records instead of using general funds to operate this program. And the final decision unit is Decision Unit E710, which is a request for IT replacement hardware and software, which is in accordance with the EATS replacement schedule. And that would conclude the major decision units for this budget, and I'd be happy to answer any questions.
Okay. On the removal of the general fund and going strictly to fee-based, how confident are you in the projections? Because it would seem that if you get 2 or 3 different sets of numbers from different folks on the projections of births and deaths, that you could end up with a glitch in your budget if you don't pick the right projection. So how are you projecting out, and whose numbers are you using, and how confident are you in those numbers?
For the record, Richard Whitley, I mean, we're able to actually project, because we're the keeper of the birth and the death certificates, we're able to actually project off the actuals, and then it is fee funded, and so passing along the fee, it currently costs a consumer $20 for a birth certificate or a death certificate. We would pass the cost on to the cost of doing business.
Okay, all right, that takes care of that one. Just wanted to make sure, because didn't want to have a problem in the future with that. Seems like that, I guess it would be, it's hard for me to wrap my brain around how you would do that, but any other committee, did you want to have some questions, Mr. Sprinkle?
Thank you, Madam Chair. I just wanted to touch really briefly on the 3 new positions that you're recommending. I think it's E230. Just curious what kind of responsibilities are these new positions going to have? And then looking through my notes, I noticed that you already have a fair amount of administrative assistance. Is the request, I believe, for another one, is that just to help with the caseload or workload or, sorry?
For the record, Richard Whitley. I'd first like to say that, in the state government system, the provision to change something, it isn't as though you can work with an existing staff, like in this example, going from paper process to electronic. And so the transition to actually move to an electronic system was essentially achieved with administrative assistant, clerical staff. Now that that's landed, there is a need to have a different technical positions to oversee the quality of the data that's being entered, the assurance that all the fields are completed. And so there is some complexity. So you'll see that there are some higher levels of positions. We also, being a general funded program, have not added to this. I mean, it was hard when we went through rounds of cuts to prioritize a service like this in comparison to a program like you just heard from early intervention. When agencies were asked to make cuts, we prioritized direct services as being those that we would try to hold harmless. And I think as a result of that, even when we've had needs in programs where maybe it seemed more like a management function, we didn't ask for any additional resources even when we needed them. So I think that's why you see an additional clerical person and then the higher level positions doing some of the electronic functions of quality assurance with the data.
Okay. Any other questions from the committee at the moment? We can go back here. On the, we're missing our technical guy here at the moment, so I'll try to handle this. I'll try to step up. On the upgrades to the newest version of the system that you're looking at, can you explain to us, is this going to be like a one-time cost? This is ongoing?
For the record, Marla McDade Williams, Deputy Administrator for the State Health Division. So it is an upgrade to a system similar to going from Microsoft Office 2000 to Microsoft Office 2010. The system we initially got in 2006. So it is our system that we produce birth and death records through. So it's not one time in the sense that sometime in the future when upgrades are needed, we won't have a need to do that. But this should maintain us for the good 7 to 10 years.
Okay, so the time limit is about 7 to 10 years. Is there a maintenance issue that'll be coming up with this, or will this pretty much set you up for a while?
It's our existing system, so we're simply buying the upgrade. Maintenance should already be in base if someone wants to correct me, but it's an upgrade to our existing system, so it's not new.
Okay. And there was an issue with the storage of records and the upgrades that you would need to be able to, needed a larger space for vault space?
For the record, Marla McDade Williams. So what we've got is, although we maintain all new records electronically for birth and death, we still have old records that are in our vault that are required to be secured. But we receive about 19,000 new records per year that are related to altering the certificate, so adoptions, name changes, paternities. So that is driving the need for physical storage of hard copy records in our vault. So the system that we're looking at is a compressed storage system that will allow us to keep records in there and not need a new vault out into the future.
All right. And how long do you think, so you think this would last you for a fairly long time then?
Yes.
Give you plenty of room. There was an issue about, which I was a little surprised, some bulletproof glass. Apparently people get a little upset.
For the record, Richard Whitley.
Oh.
So in Vital Records, we do have a direct service component, which is the issuance of birth and death certificates to consumers. The building that we're in is not secured. We're remotely located. We're not a state building, so we don't get the we're not afforded the security of Capitol Police like other state buildings. We have had incidents with irate consumers who perhaps don't have all their proper documentation actually hit the window, which is not, it is breakable. So when we actually met with staff about all the safety concerns, this was by far the overriding concern of staff is the protection. They're in a locked area, but the window, large glass window, is not shatterproof. And so I think it's from a perspective of protecting our public, or our employees, it seemed like a reasonable request to include in the budget.
Okay, that sounds very reasonable. I just was a little surprised to see it, so. Okay, committee, any other questions on this particular budget item? Seeing none, very good. As we go to 3194, we see that there are no major issues that the chair would bring up. If the committee has any questions, we'll address them, but if not, we'll move on. Seeing none, very good. On item number 3215, communicable diseases, Mr. Whitley, would you like to go ahead?
For the record, Richard Whitley. So budget account 3215 titled Communicable Diseases. This is the budget where our HIV/AIDS program resides, including our AIDS drug assistance program. And so these programs are reliant on federal funds and, again, as I stated in the beginning, would potentially receive up to a 9% reduction as a result of sequestration. The AIDS drug assistance program, currently we have about 1,400 active clients in the state. Of those, 629 receive their HIV medication from this program. The decision unit in this budget, E225, requests an increase in drug rebate revenue to fund additional HIV/AIDS services. How this works is the pharmaceutical companies do provide rebates to states for the purchase of medication. We did revert general fund previously because we did receive these rebates. They're hard to project. Each drug company actually has their own calculations for what states will receive. We know what we've received historically, but as I said, each drug company makes those changes. Actually, it's been these rebate funds from pharmaceuticals that have kept us from having a waiting list in this program. I'd be happy to answer any questions about the rebates.
Well, I think one of my, let's just go on because it's intermixed with everything that's going to be happening with the health exchange and folks moving around and how do we make sure all their services get taken care of. So let's go ahead and finish and then we'll go back through all the questions.
For the record, Richard Whitley. Decision Unit E710 requests replacement IT in accordance with the EATS recommended replacement schedule. And finally, Decision Unit E805 reclassifies a Management Analyst 1 to a Management Analyst 2 based on significant changes in the duties of this position. So that would conclude the decision units in this budget, and I'd be happy to either launch into the impacts of Affordable Care Act or answer questions.
Well, if I could just address, since we just talked about the drug rebate program and how the money is used to help the patients deal with their health insurance premiums and concerns, as we move forward through the Affordable Care Act, we're going to have these dollars that they can use depending upon where their income is, whether they're above or below the 138%, they can either go onto the health insurance exchange or not. I'm sure a number of them are probably Medicaid eligible, and if they're just above Medicaid, then they may be included in that now too. There's the federal premium subsidy, and then there's what the drug rebate has been paying for over the years. There's 15 pieces of this puzzle. Have you figured out how they're going to fit together? And if you have, do you have directions for us?
For the record, Richard Whitley, I'd first say that no, there are moving parts to this. You mentioned under Affordable Care Act, the Medicaid expansion. We are confident that the people that will be eligible for Medicaid expansion, the formulary for Medicaid expansion will include the medications currently on our formulary. We don't know for certainty yet on the exchange what the formulary will be for, and that's about half. I think I failed to mention in the beginning. This program serves up to 400% of poverty, and so about 50% of the current clients would fall under Medicaid expansion. The unknown part is with the exchange in terms of what their formularies will look like. I would also add that correctly as you summarized, this program has become more of just directly purchasing medication, but also assisting with insurance assistance. That's either keeping someone with insurance if they've lost their job through COBRA, or assisting with co-pays and deductibles if that's a barrier to receiving medication. Certainly more cost effective than purchasing directly medication, and in the case of insurance, assistance allows them to have a broader coverage. This is a moving target. I think the essential thing in this is we can't let any of the people we currently are committed to receiving medication go without medication. That's been the challenge in this program when we've neared a waiting list, is we can't remove people from the program, so like to lower the poverty level for eligibility. Those have always been challenges, and so you see that the budget does request full coverage, but I do believe that we will not be utilizing all that is budgeted, but I can't say for certainty because I don't know yet what the exchange will be covering in terms of medication. So this budget was built to maintain the coverage for the existing clients, and there are variables, though, that will certainly relieve the burden from the state in terms of covering costs.
And if I may, you feel confident that the formularies will be covering most of these drugs. I'm not sure on the health insurance exchange. We don't know what they will cover, and then we get into the subsidies, and then what procedures have you set up to make sure that these folks get the continuum of care that they need to stay healthy?
For the record, Richard Whitley, we're working with the exchange so that we don't have those gaps. I mean, I feel confident in saying that we've never had a patient go without medication on this program. Even when we faced reductions in other programs, I mean, the rebates are an example of that. Staff aggressively went after all the resources that we could pull in. Again, I will provide you, as soon as I have all the details of what is covered, how we will make that transition. We went through this in this program early on when people had health insurance but were afraid to use their health insurance. And as we saw the program getting at capacity, we had to safely transition those folks to their insurance. And so we've been through this before. I think our providers, who are primarily UMC Wellness, AFAN in Las Vegas, and the Hopes Clinic in the North, this is the work they do. They don't let clients fall through the cracks. We're working with them, and as the information on what's covered becomes more available, we will have a plan, and we'll share it.
On the sequestration side, when you look at the numbers, do you have a number that you're comfortable with that we may need to address, and have we figured out how that reduction will be handled?
For the record, Richard Whitley, for HIV prevention, it's about $218,000 if it's the full 9%. For Ryan White, it's about $759,000, and that's the HIV a base grant, which provides services as well as the earmark for the medication. There is, though, I would offer that in the early guidance that we've received from HRSA for the Ryan White Care Act, there is a phrase in their document is that there are some allowances for holding some federal programs harmless, and that Ryan White is actually a program that could be held harmless. We've not received official notification, so our planning right now is with the anticipation we would lose the resource, but there is that possibility that the program could be held harmless. Now that means that another federal program would have to absorb that cut, and there would be a reduction somewhere else.
It's get it now or get it later. Right. Okay. Are there any questions from any members of the committee on this? Yes, Mr. Sprinkle, please.
Thank you, Madam Chair. Just a follow-up to what you just said. Do you have any idea when we would know?
For the record, Richard Whitley, you know, the Office of, gosh, Marla, you just told me this, the grant, Management and Budget, sent, you know, an overview document, but what we're getting now are by program, you know, the notifications, and it's really just a restatement that the possibility of reduction is up to 9%. It really hasn't been very helpful in terms of getting the information to be alarmed, or, you know, all the letters are indicating that they will work with us, which is great. I mean, and how we would approach it, like I said, is like we would receive a new grant, renegotiate like what the funding amount is, what the priorities are in the program. Likely it'll result in needing to come to IFC if we change spending categories in those grants. But it is at least helpful that there's flexibility being presented to us. So we're developing our plans, but not because we have clear direction from the federal government.
Okay, thank you very much. Oh, and I'm not sure, you probably said this earlier, but how many people are actually being served through Ryan White right now?
For the record, Richard Whitley, there are 1,400 active cases, and that includes all the various insurance assistance. But for the AIDS Drug Assistance Program, the piece that the general fund complements, 629 people statewide receiving medication.
Okay, good, thank you. Gives us a good perspective on it. Any other questions from the committee? Seeing none, I believe we can move on to 3218 then, the Public Health Preparedness Program. I think the only questions we probably have on this are the new positions. So if you'd like to give us a brief overview and then go into the new positions, that would be helpful.
For the record, Richard Whitley, the new positions are based on grants that we've received. One is the Decision Unit E225, and that it has a Health Program Specialist 2 and an Administrative Assistant 2 for the Emergency Systems Advanced Registration and Volunteer Health Professionals Program. Moving on then to Decision Unit, Decision Unit E710. Well, I'm sorry, I apologize. You wanted to hear just the positions, or?
I don't think we have any questions on any of the other decision units. I think it's just the positions, so I figured we'd focus on the interest. So, and I'm sorry if you said this, what programs are these new positions going to be supporting? It was the volunteers?
For the record, Richard Whitley, Emergency System Advanced Registration for volunteers, for health professionals. So it's creating a registry, a database, again, a federal program that we receive federal funds for to implement, but to have a reserve of medical professionals who are signed up who could be utilized in a public health emergency.
Okay, and are these going to go through this biennium and into a future biennium, or is this a shorter-term project?
For the record, Richard Whitley, this is a typical grant like the Health Division receives, which usually comes in a 4-year grant period.
Okay. And are there still going to be contract folks needed to support this, or this will be totally grant positions?
And for the record, Richard Whitley, I'm told that this is just the state positions. We will not be using contract positions for this program.
Okay, all right. Committee, did you have any other questions on these new positions? Seeing none, thank you very much, Mr. Whitley. Appreciate that. We can go ahead and go on to 3219, Biostatistics and Epidemiology. My goodness, I said it right this time. I'm getting better at that one. I've had to practice. So if you go ahead, that'd be fine.
For the record, Richard Whitley. So in 3219, we have 8 grants in this budget account that are, again, anticipated to be affected by sequestration. There's the Behavioral Risk Factor Surveillance Survey, Epidemiology and Laboratory Capacity Grant, TB, STD, HIV surveillance, hepatitis, biosins, and then State Systems Development Initiative. And again, the cuts are anticipated to be as high as 9%. And so the cuts per grant would range from $6,000 to $85,000. And again, we would apply the same prioritization to this grant, to these grants. The decision units in this grant, E225, requests a state medical epidemiologist position to direct epidemiological investigations related to public and behavioral and primary care. Decision Unit E710 requests replacement IT in accordance with the EATS recommended replacement schedule. Decision Unit E737 adds a new subgrant from, or a new grant from the Department of Education for the Youth Risk Behavioral Survey. Decision Unit E738 adds a new federal grant to promote timely exchange of electronic health-related information. 3 full-time positions will be added with this program. And that concludes the decision units for this budget.
Okay. Let's go back to the new medical epidemiologist and please help me understand the differences in the job duties as far as the state epidemiologist and the discussions we've had about our state health officer and why a medical epidemiologist versus, I guess, a regular epidemiologist, and this is when I really miss having a doctor on the committee. Please, in layman's terms, help us understand.
For the record, Richard Whitley, this is a position that through our preparedness grant, we actually, when you get a federal grant, you often have the opportunity to either get assistance from, like in this case, CDC, the Centers for Disease Control. You have the opportunity to get direct assistance, which is funding, or they can provide the assistance. We had a medical epidemiologist provided through our grant who was the first for us to have. And he worked for us for about 1.5 years and then took another federal job. So in our grant application, we actually applied to have the direct funding directly to the state so that we could hire our own position. You'll see that we requested in the budget for a senior physician level. There is no job classification for a medical epidemiologist. The benefit that we saw, though, from the function when the federal assignee was in our state was utilizing. Typically, our state epidemiologist focuses on communicable disease and then has the added responsibility, because we don't have local health authorities in rural frontier Nevada, to be the direct epidemiologist for disease investigation in rural frontier Nevada. So that's the role of the state epidemiologist, primarily focusing on communicable diseases and outbreaks and prevention. The role that this served and why it was so important to us to actually ask in our grant to rather than have another person placed in our state and perhaps be time-ended again, was to have the funding and create it. Was the focus then was on areas that we've never focused on in public health in our agency, occupational health, using the epidemiologists to focus on chronic disease and wellness, which I think become only more important with the Affordable Care Act and the coverage for preventive health. So to be able to, we're really rich with data, as I mentioned in our budget with our vital records. We have from birth to death data that tell the story of what the health status and where prevention opportunities exist. What we don't have is the workforce to actually do the analysis and provide the technical direction on where prevention strategies need to go. And so we felt that this position was really of great benefit to our state, and we wanted to continue it.
Would there be an overlay of mental health involved?
For the record, Richard Whitley, we included, using the framework of Affordable Care Act, we used the framework of primary care that included both preventive health and behavioral health, and with behavioral health including substance abuse and addiction. So it is comprehensive in terms of where the focus, but it does focus in areas where our state epidemiologist historically has not focused.
Okay, thank you. On the BioSense surveillance application, can you tell us what progress has been made on the program and where we stand as far as drawing down the federal funds?
For the record, Richard Whitley. So this is an actual competitive grant that we received to do syndromic surveillance.
Okay, you've got to explain that one.
So, you know, there are diseases in our state that are reportable by the disease. That's, you know, fairly easy to track. Providers report it. The epidemiologist gets notified. But in terms of issues such as flu symptoms or...
you could study this building for the last 3 weeks. I mean, that'd be easy.
Well, but that's an example. Is there an outbreak of something occurring in a community, in a facility? So this actually extends some activities that the Health Division had done previously without any federal resource, which is to monitor like over-the-counter medications in agreement with pharmacies. Anti-diarrhea medication, what's the utilization if there's an increase in that? Is there something going on in that area? And so that is the syndromic surveillance. This is a federal grant. We applied for it and received it and are implementing it within the guidelines of CDC.
Have we pulled down the federal funding on that yet, or how is that working?
We did do a work program this fiscal year. For the record, Stacy Johnson.
Thank you, Ms. Johnson.
We did do a work program this fiscal year. I won't remember exactly which IFC. We asked for contract employees to get us through this fiscal year until the positions could be approved through the budget process. I can't tell you exactly how much we've drawn down, but we do have the authority and they have moved forward. I'm sure there has been an amount that's been drawn in, but I don't know the exact amount. I could get that information.
Okay, I think you're going to need to work with staff on that because we don't see where the money has been drawn down. We have some concerns, and we understand it's there for you to use. We just want to make sure the right monies are used in the right silos. So if you would please work with staff on that so that we could get that clarified, that would be very helpful.
Okay.
All righty. And I don't think I have any other questions on that particular budget item, if the committee does. Seeing none. When we go to budget item 3230, chronic disease, the chair had no major issues. If the committee had any questions on this budget item, I'd be happy to open it up for that. Seeing none. So I think we're fine on the chronic disease front. Let's move to budget item 3222, maternal child health services. Thank you.
For the record, Richard Whitley, budget account 3222. Maternal and child health assures and provides health education, preventive activities, and quality assurance and access to health care services. This budget account has 4 grants that are, again, anticipated to be impacted by sequestration. The Maternal and Child Health Block Grant, the Home Visiting Grant, the abstinence grant called Personal Responsibility Education Program, and then a rape prevention grant. Again, the cuts are anticipated to be up to 9%. In these grants, that would range from $16,000 to $147,000. Decision Unit E22. Yes?
Just a minute. Are we on the right page? Did I miss something? Are you looking for something? Okay, go ahead. We thought we were confused for a moment, but apparently
me?
we're not confused. So, not thoroughly, anyway. So please, I'm sorry to interrupt you. I thought some folks were not on the right page, so I wanted to make sure everybody was together. Please, proceed.
Okay. For the record, Richard Whitley. So then Decision Unit E227 reduces 1 Health Program Specialist 1 position funded with newborn screening fees to a half-time position due to analysis of program needs. Decision Unit E228 requests a new Administrative Assistant 3 position for a newborn screening program to assure follow-up activities occur as a result of positive newborn screenings. Additionally, this requests an increase of newborn screening fees. Decision Unit E710 requests replacement IT hardware and software in accordance with the EATS recommended replacement schedule. And then finally, Decision Unit E906 transfers the State Suicide Prevention Program from the Director's Office to the Maternal and Child Health Services budget account. And that would conclude the decision units in this budget.
All righty, thank you. Were you on the same page now, Senator? Okay, good. I just wanted to make sure. I was a little lost at the moment, too, so I just want to make sure we're all on the same page. Okay, on the metabolic screening, I will admit I'm a little confused on the changes in the program. We were planning on having it go to the School of Medicine. That's not going to happen in the near future from what I understand, and we're going to stay with who we currently have doing it now. And we're looking at some fee increases, but I'm not sure if those fee increases are enough to cover what's actually going to be tested for and the administration of all the tests. So if we could go into the fee increases on that, I'd like to understand how all that fits together.
For the record, Dr. Tracy Green. Okay, maybe I'll just start from currently, we are still anticipating the transition to the university. We have had some delays in the purchasing of the equipment. We have found that the university has needed to move to an RFP process, and so that has pushed back the time clock for the transition from what was anticipated to be late in 2013 to early in 2014. So the plan for the transition has not changed other than the timing of the transition.
Okay, that, yeah, Senator Smith.
Were you done? Because
actually-
I can let you keep
Well,
going.
no, we can get into the numbers. You go ahead, and
Okay.
then we'll address the other issues.
Thanks. Thanks, Madam Chair. I just really wanted to kind of go back. I thought I remembered this issue from the Health Committee that I served on last session, and I think you had a bill that sort of set out the order of how this happens, but I don't think this follows that order. So if you could address that.
For the record, Richard Whitley. Actually, it wasn't an agency bill. I think former Senator Wiener had a bill about the newborn screening. We currently contract with the state of Oregon with their health science system, and the bill would allow us to bring the program into our state, to our School of Medicine. It really is, the bill allowed us to do that. It didn't really lay out a timeline. It did, though, allow that if the School of Medicine in Nevada didn't take on newborn screening, that we would then be open to the private sector in Nevada to take a look at doing newborn screening.
And that's what I was looking at, is I just remembered it as, and I apologize, I thought she had that bill for the agency, but at any rate, it just lays out, when I went back and looked at it, the order in which we would contract, and so it doesn't look to me like this follows that bill.
For the record, Richard Whitley, well, I think we're still working with the School of Medicine. I know that Dr. Schwenk from the School of Medicine is here and planned to speak during public comment to give an update. But I guess the way we viewed it is we never stopped working with the School of Medicine in terms of that first priority to see if we could bring this contracted activity going to a university in Oregon into our own state with our own university system. We have been working all this time with Dr. Schwenk and his staff at the State Public Health Lab to try to bring this into Nevada. So I guess we haven't arrived at the place then to engage the private sector because we haven't said that we couldn't bring it into Nevada yet through our School of Medicine.
I'm just interested in bringing work back into this state, so just want to make sure that we're following, what we set out, and what we heard last session would be a better idea for us. So I'll wait to hear from Dr. Schwenk. Thank you, Madam Chair.
All right, and on the fees, excuse me, apologize. And on the fees, Mr. Whitley, what we're planning on the fees, will they actually cover the cost of the testing, and will there be enough there to deal with the, I know there's like 2 major tests and then some other tests along the side, but then there's also the administration. I just want to make sure that, if we are going to increase the fee and people are going to bite the bullet this time, the last thing I want to do is find out it wasn't enough and we have to come back and do it again in the future, because then it's, oh, well, they did it 2 years in a row. If we're going to do it, I think we need to make sure that we land on the right number.
For the record, Richard Whitley, yes, we do. We did the analysis of this program. It is fee-based. The last time we raised the fees to this program is when we added a test for cystic fibrosis. So what's triggering it now is actually the Oregon lab has notified us that their cost will be increasing, and so it is based on what our anticipated charges would be. So the analysis would be that, yes, the fee increase would cover the cost.
And then the administration.
Including the administration.
Just want to make sure. All right. Mr. Sprinkle.
Thank you, Madam Chair. Just along those lines, so those fees are based off of projected, I would guess, birth rates. Feel confident in the projections for this next year associated with the fees that you're looking at?
For the record, Richard Whitley, yes. I mean, it's the data that we have to really base this on, and so looking at birth rates over time, that is how we've approached this budget in the past. So I'm as comfortable as I can be unless something happens with births.
All right. Thank you. Thank you very much, Mr. Whitley. Any other questions from the committee on this particular item? Did we want to go ahead and take public comment now on that particular issue, if we could? We had someone here who wanted to make comment on this, so to get that out of the way, and because we know we're going to bump up against time, so we want to make sure, since you're here today, you had an opportunity to speak. Please
Thank you, Madam
introduce
Chair.
yourself for the record.
I'm very appreciative. Tom Schwenk, Dean of the University of Nevada School of Medicine. I simply wanted to confirm Richard Whitley and Dr. Green's assessment of their ability to work closely with the School of Medicine to conduct this program. I understand that discussion about moving newborn testing from Oregon back to the state has gone on for some time, predates me by some time, including the last legislative session. When I arrived in July of 2011, this was one of several major pending issues that confronted the school, but I considered it to be of high priority for a couple of reasons. One is simply what Senator Smith said, which is that I think this is the kind of service that, if possible, should be conducted within the state for the state residents. Perhaps more importantly, I think the School of Medicine is expanding its programs in a number of areas to serve the state, and we consider this to be one in which we can do so with very high quality. Our Department of Pathology and the State Public Health Lab are expanding their testing capabilities significantly and would encompass this as they add the necessary equipment for which the RFP is being constructed. Perhaps more importantly, we have a growing and very successful School of Community Health Sciences led by Dr. Trudy Larson, who herself is a pediatrician, HIV/AIDS specialist, but also with public health expertise, and that school is growing to eventually become a full school of public health. And this is the type of function that we believe is a perfect marriage between the School of Medicine, the School of Community Health Sciences, and the state to conduct a very high-quality service. We have all of the consultation services in place for the positive tests, and really it's a matter of the testing capability and then to launch the program with appropriate collaboration between the school and the state in its administrative staff.
Thank you very much for being here today. Yes, Senator Smith.
Thank you. I'll make it quick. So it's about the equipment, not personnel? You
Correct.
have an RFP out for the equipment, but you have the personnel?
At this point, it's basically an equipment issue, and we have the personnel on both sides, the state and the School of Medicine, either in place or about to be in place. Much of this will be based, for obvious reasons, in Las Vegas, where the birth rate is much higher.
And you have the funding, obviously, then, for the equipment?
Yes, in anticipation of the contract with the state and the appropriate fees. We think that we can do this as efficiently and perhaps more so than the current and future contract with Oregon would cost.
Is this the kind of thing we could use the Knowledge Fund for? Because isn't that funding about being able to build research and equipment and?
Well, actually, that's a very appreciated question. One of the lesser appreciated aspects of this program is that there is huge potential for clinical and translational research related to the use of these samples for genetic purposes. And there are very standardized approaches to how this is done on a de-identified basis, in which there is no identification to the samples, but as a what's called a biorepository of specimens that can be used for research. This is actually one of the lesser appreciated but really significant aspects. And the Knowledge Fund, I believe, would be perfect for that piece of it, not necessarily for the operational piece of the testing, although I appreciate that suggestion, but I think the research component is equally important.
Right. Okay, thank you. Thanks, Madam Chair.
Thank you, Senator. Any other questions from any other members of the committee? Thank you very much for being here
Thank you for
today.
the opportunity, Madam Chair.
With that, I believe we can go ahead and close that budget. I'm sorry.
One last question on this.
Yes, Mr. Sprinkle, I'm sorry. Go ahead.
Thank you, Madam Chair. I apologize, a little late question here. I just was looking, you had already proposed in the Health Committee as far as transferring the suicide prevention. I just wanted to specifically get to the budget. When you're looking at expanding suicide prevention to many different areas, as you had described to me before, just curious why you feel that from a budgetary standpoint this is the best place for this to land.
For the record, Richard Whitley. I think that the title of this budget maybe is a little too narrow, but the programs that reside there engage in activities that are around injury prevention, of which suicide, prevention is injury prevention. And so I think it's more for the activity so that there's greater capacity. I, actually did look to see, like, would this be better placed with our data and epi group? But it misses the programmatic function. It needs to utilize the data, like we worked on with the program for veterans and suicide. It needs to access that. But in terms of the program function, the function in terms of the strategies are really that of injury prevention. And this is the budget account in the health division that does engage in those behaviors.
Okay. All right. Thank you, Mr. Sprinkle. All righty. With that, we'll go ahead and close that particular budget item. And we'll move on to, and I want to make sure that, does the Senate need to be on the floor at 11? So we're at about 1:45. I believe we'll try to do one more and then go from there. Is that okay? We'll go ahead and open up 3224 and discuss that particular budget item.
For the record, Richard Whitley, this is Community Health Services, which is our public health services provided in rural frontier Nevada. The decision unit E2225 eliminates 1 community health nurse position and 3 community health nurse 2 positions due to a reduction in funding. Decision unit E275 adds 3 administrative assistant 1 positions to provide administrative support to the Lyon County Community Health Clinic. Decision E710 requests replacement IT in accordance with the EATS recommended replacement schedule. Decision unit E907 transfers the health program specialist that serves as the tribal liaison for all of the divisions in the department to the director's office. The decision unit E908 transfers the community health nurse manager from the nursing budget account to the health division administration budget account as part of the integration between health division and mental health and developmental services. And that would conclude the decision units for this budget.
Excuse me, I apologize. The Preventative Health and Human Services block grant revenue has been decreased. I was just curious as where the cause of that and how that affected the programs.
For the record, Richard Whitley. So the Preventive Health Services block grant does support some of the nursing activities. It also supports other public health, primarily chronic disease programs statewide. So this budget account and this program, the rural program, is a recipient of some of those funds. So it really is reliant on the prioritization of that grant. It really is the recipient then of some of those awards that then are utilized statewide. In terms of the elimination of the positions, those positions actually have been vacant for, one has been vacant for 2 years. We transitioned some of our nursing services during the biennium in Douglas County with Carson City, and so nobody was laid off. We just actually haven't filled these positions as a result of closing that clinic. We also closed our clinic in Zephyr Cove due to clients not requesting the service. We had a full-time FTE dedicated, and the requests for services lent themselves more to a satellite approach, like for immunization clinics, rather than having a nurse stationed in the clinic. So as we did rounds of reduction with general fund, because this budget relies on general fund as well as grant funding and as well as county contributions, we looked at utilization of our sites. And this program is mobile in that it has nursing clinics, but it also has satellites. And in many ways, we found that to be an effective way. We do all this work in collaboration with the county health and human services in terms of, a partnership with where they also see the services best need. But these positions that are eliminated, funding reductions are one factor, as well as the elimination of one clinic.
And as the community health nursing model changes with the Affordable Care Act coming in, have there been discussions on, more folks will have insurance? Are you set up to do billing if it is possible? And if it's not needed, are we looking at future reductions?
For the record, Richard Whitley, yes, we are set up for billing. The issue in rural Nevada is not always payer source. It is actually not having providers, and so we have fulfilled that role in some communities, being the sole provider. Immunizations are a good example where people may have coverage, but there are no vaccinators in the community. So we do have the infrastructure for billing. I think the challenge that we've been trying to work with is how to partner with the rural health clinics. In rural Nevada, you're probably most familiar with the federally qualified health centers, but in rural Nevada, we have rural health clinics associated with the hospitals. And it's really how to integrate so the person can also get access to primary care. Perhaps we serve in that preventive health role.
All right. And on the administrative assistance, the issue with Lyon County and the agreement that was made for negotiating the county reimbursement on those assistants, where are we with that?
For the record, Richard Whitley, how this program functions in most of the rural counties is that the county will contribute the space for the clinic, as well as clerical support or administrative assistant support. So you actually have a clinic functioning with a county employee and a state employee. Sometimes that works very well, and sometimes it doesn't work very well.
It's one of those times when it doesn't work very well?
I think it can work better with it being a single system.
That's very polite. Thank you. All righty. If there was an agreement for them, I'm just trying to understand. We want the service to be provided, and we want the appropriate. We just don't want to have to take monies from one place to pay for another when there was already an agreement. So I just want to make sure that in the end it all works out and the appropriate people are paid or pay for the appropriate services.
For the record, Richard Whitley, yes, we'll assure, just as we have to with our grant funding, that positions that are being provided and providing a service are aligned with the appropriate funding stream.
Okay, good. Just to make sure. We understand you're going to get there, but we always have to ask and double check. So with that, committee, did you have any other questions on this particular budget item? We have one left. Do we want to just power through? Okay, we've let the Senate know that they're just going to, that we're going to be just a couple minutes late, so we'll go ahead and power through and get it done. We will go to budget 4547, the Marijuana Health Registry. So, Mr. Whitley?
For the record, Richard Whitley. And so in budget account 4547, decision unit E581, it allocates cost to fund the online system allowing for public access to apply for the certificate needed for this program. I gave an overview of this in our last budget presentation of this electronic system. The cost to this program is 10% of the overall cost for the tire. And that is our only decision unit in this budget.
Okay, I think the issue that arose were the revenue projections. These revenues are used in other areas, and with the change in the revenue stream based upon the policy on how the internal policy of permitting one application at a time, I guess I need to understand what the previous policy was what the change that was made, what authority that change was made under, and it seems as though it could have a significant impact. So if you could address that, please.
For the record, Richard Whitley. So in how this program is laid out is that people pay to get an application, and then that application is processed, and they're issued a card if they meet the criteria. What was happening in this program is that there were brokers set up primarily in Las Vegas, purchasing applications from our office by the hundreds, and then acting as a go-between with consumers, and what would happen is sometimes when they would disappear, the consumer would be left believing that they had in fact received and filled out an application to the State Health Division, and were very angry that we in fact had no record of their obtaining, but they paid out of pocket. I made the decision. I don't know. There's nothing in the statute that says I can't make that decision, but I made it because of the consumers with health conditions who thought that they were receiving applications from the State Health Division. I do believe that that is a factor in the reduction of the revenues seen in this program, but it seemed and continues to seem to me to be the appropriate stance from a public agency. I guess from my perspective, the goal wasn't to bring revenue into this, but to actually protect the consumer who is actually applying for a card. But that is the variable to this. You can see we have charts and graphs that show, when we made the policy change that the revenues did reduce.
Okay, and we do want you to protect the public. We just need to understand what was going on, and just wondering if there's maybe an in-between ground that might be able to be adjusted, because this money is designated for other programs, and so we always want to, we have to put the safety provisions in, but yet we want to make sure that if we're just depending upon the processing times, that we're not slowing it down to the point where we're keeping people from getting their card also. So there has to be there's a fine line in between the two, and we just want to make sure that they're protected, but yet they're still getting the service that they need. Yes, Mr. Sprinkle. Yes, sure do.
Thank you, Madam Chair. I'm just curious, who exactly were these brokers? Were these just like private entities? Are these physicians? Who was doing this?
For the record, Richard Whitley. When we looked into, because again, the consumer complaints were that they would name the person, that they were actually folks who were set up as dispensaries also. I think if in Las Vegas there are billboards for various folks, and they were some of those folks. But what would happen is, they would often get arrested. This broker, I'm calling them a broker, that may not be the appropriate term, but they, in acting in this go-between way, they seem to have some influence. We also, in looking in and hearing from consumers, found that they would help navigate them to providers who would in fact prescribe medical marijuana. So they were providing a service, but it was that purchasing in bulk of the applications, and then not following through, which I think is what I responded to.
Any other questions? No? Seeing none? Thank you, Mr. Whitley. Okay. And as far as the transfer of funds that will happen to SAPTA in the future, have we done an analysis on that?
For the record, Richard Whitley, yes, we do, and we continue to communicate. You know, this is really three agencies, DCFS, SAPTA, and the Health Division, and, you know, it provides, these funds provide evaluation and services for families for substance abuse, and so it does go to, you know, a need, but we are communicating with them. There are other funding sources that do supplement those services. Those same families are eligible for some of the other SAPTA services. This just added another funding stream to a need that you know, can always use more resource.
Okay, and is there a projected reserve on the marijuana registry fund? And if you have 13 and 14, that would be helpful. If not, you can always get it back to us.
Stacy Johnson for the record. I'm not exactly sure what the projection is for 13, so I can get that back to you. Right now, we're projecting at the end of 14 to have approximately 270,000, and at the end of 15 to have approximately 186,000 in our reserve.
Okay. If you could provide that other number when you can, that would be very helpful. You can just relay that with staff. Committee, did you have any other questions on this particular budget item? Okay. Our, seems like a number of these are just broken. Okay. With that, I think we'll go ahead and close the hearing on that particular budget item. Go from there. We'll go ahead and open it up for public comment. I know Mr. Lovegren had wanted to make public comment. If there's anyone else that would like to make public comment at this time. Thank you, committee, very much for your hard work. We've accomplished our task for today. Mr. Lovegren, welcome to the committee.
Good morning. Thank you. My name is Barry Lovegren. I'm a private citizen representing only myself, and I'm here to testify in support of budget number 3222, the funding for maternal and child health services. And I'll be very brief. At last session, I testified before a number of committees about how substance abuse treatment of pregnant women had declined by half since 2004, despite there being no corresponding decrease in the number of pregnancies in Nevada, nor in the rate of substance abuse in Nevada. I ascribe much of that decline to the Substance Abuse Prevention and Treatment Agency failing to meet the federal requirement to publicize that funded substance abuse treatment programs offer pregnant women treatment and admission priority. Besides that failure violating federal law, it simply does no good for programs to offer this if nobody knows about it. Since last session, substance abuse treatment of pregnant women continued to fall, and it now seems to have stabilized at a bit over a third of what it was in 2004. And the availability of treatment and admission priority for pregnant women still is not being publicized. I brought to the attention of the Health Division that it's failing to meet its mandate under NRS 442, the Maternal and Child Health Statute, to conduct a public education campaign on the dangers of drinking during pregnancy and how pregnant women can obtain substance abuse treatment and other services. I told Mr. Whitley, Health Division Administrator, that in the course of meeting that state mandate, the Health Division could also meet the federal mandate that Nevada publicize the availability of substance abuse treatment and admission priority for pregnant women. And the response? The Health Division is going to meet both the federal and the state mandate. Maternal and Child Health Services is in the process of developing public service announcements on the dangers of substance abuse during pregnancy and on the availability of substance abuse treatment and admission priority for pregnant women. I want to commend the Health Division and its Maternal and Child Health Services for the responsiveness, and I very strongly support funding of the Maternal and Child Health Services. Thank you. Any questions?
Thank you very much, Mr. Lovegren.
Thank you.
Job well done. Appreciate that. Any other public comment?
Thank you, Madam Chair. For the record, Jeff Fontaine with the Nevada Association of Counties. I'll also be brief.
I'm here to speak to budget account 3194, which is the Consumer Health Protection Services. One of the county assessments that was enacted last session, 2011, is in that budget account. It's certainly not the largest cost assessment that was enacted, but perhaps one that's unique. That's because there are no general fund dollars that we can tell of in this budget account, and they do have a dedicated revenue source. They are a fee-based regulatory agency that has their fees approved by the State Board of Health. So we're aware that, in fact, in 2010, that agency had, in fact, proposed a fee increase to cover their services. That was not pursued. So we would respectfully ask that you consider the fact that they have the ability, the authority to raise fees to cover their expenses in lieu of assessing the counties for those additional costs. And so I'd be happy to answer any questions.
All right, thank you. Any questions from the committee? Seeing none, thank you very much. Any other public comment to come before the committee today? Well, thank you all very much, committee. We are adjourned.